morning to everyone. Dr. Sandeep Diwan told many times to me that I've chosen the speakers in whichever they are good in several times. Little did I realize the meaning for this, because yesterday he gave me inadequate brachial plexus block and today he gave me failed spinal anesthesia. How many of you here have encountered the problem of failed spinal anesthesia? This is the best ever crowd I've seen, honest all the time. Because many times you ask a question based on the seniority, they will see if the PGs are around, then many of the times you see the hand going up like little bit, yes. But here I see everybody going up top, and then I think this is the most honest crowd we have ever seen. This is one of the most menacing problems, especially so when you are working in an institution and people call you to give spinal anesthesia for a VIP, and the head of the department is asked to wash with 14 people sit closely watching what they do, and then he very proudly sees the CSF coming out, has a glance at everybody around to see how I got the CSF, injects the drug, and then takes the needle out promptly, and after 2 minutes you ask the patient to lift the leg and it goes too high as far as the roof. So this becomes the most toughest proposition for us, and especially so when we become more senior. In 1922, Gaston Labat said 2 conditions are therefore absolutely necessary to produce spinal anesthesia. One is this puncture of the dura mater, and the next is the subarachnoid injection of an anesthetic agent. It looks very, very simple, but then it's regarded as one of the most reliable of the regional block methods. And spinal anesthesia is considered to be very reliable because the needle insertion technique is pretty straightforward. Backflow of CSF is a clear indication of successful needle placement, and local anesthesia spreads easily through the CSF medium. So when do you get a competency in giving spinal anesthesia? One of the studies has indicated the level of competency in administering spinal anesthesia is attained relatively quickly. More than 90% of your spinals will become successive if you have got 40 supervised spinals given, some senior is watching you, and if you're given 40 spinals, then it means it's going to be successful. But in spite of all this, it's a menace. It's something which really troubles us a lot, even if you have 30 years of experience that you have. Failed spinal indicates either there is no block or there is an inadequate block in terms of its extent, the quality, and the duration. And the incidence of failed spinal differs from institutions to institution. Where it's a teaching institution, the incidence has 7%, but the average incidence is 4%. And the common cause, what is the common cause of failed spinal according to most of us here? Yes? Honestly, you should tell. Most of us definitely blame the drug, because that is the only one which cannot speak. And then if you are the head of the department, you power upon, say the storage is not good, this company is not good, this batch is not good, please fish out this batch and note down this batch and immediately remove all this batch, return to them, get a new batch of drugs. Yes or no? Yes, so that is because the drug cannot speak, neither the company people can't speak against us. So, but the reality is it's an error in judgment in administering that results in block failure. It's because of the clinical technique, because of the inexperience, it's because failure to adopt meticulous approach while giving spinal anesthesia. Spinal anesthesia the procedure itself can be divided into 5 phases. One is the process of doing a lumbar puncture. Second is injecting the solution. Third one is the spread of the drug through the CSF. Fourth one is the drug acting on the spinal nerve root and the spinal cord. And the last one is the subsequent patient management. There could be a problem in each one of the steps to produce a failure in getting an adequate block. I would like to ask a question. What is the depth of the spinal space? Have you ever thought of that? It was very surprising. Even I've never thought of this until I started preparing for the talks. The depth of the spinal space where the CSF flows is hardly 2 to 3 millimeters. That is why many times we'll end up in problem. It's such a small space. I've never realized that it's such a small space. And we'll talk about the clinical significance of this a bit later. So when you inject the drug inside, after you get a free flow of CSF, when you inject the drug undergoes 3 phases inside the CSF. First one, the minute you inject, in the first 2 minutes, 1 to 2 minutes after injection, it undergoes dilution. So the local anesthetic gets diluted in the CSF, which has got a variable volume. This is very important that all of us have to realize. The spinal CSF fluid can vary between 28 ml to 80 ml. This is done in a study. And more the CSF volume, and suppose if you give less the drug, the action is going to be less. And one of the common causes of a failed spinal anesthesia is thought to be increased in the CSF in that particular patient compared to the others. And there is a condition called lumbar ectasia where the subarachnoid space it's very dilated and the CSF volume is more in the lumbar space. In these patients, again, the inadequate block is more common. Phase 2, after dilution, phase 2, the process is called as diffusion. For the next 2 to 6 minutes after giving the drug, the local anesthesia diffuses into the nervous system. The concentration gets reduced further in the CSF during the phase of diffusion. The third one is the phase of distribution. The local anesthesia gets attached to the receptors and the neural tissue, producing its clinical effect. So after you inject the drug, it undergoes 3 phases. Now, what are the common causes? Number 1 is failed lumbar puncture. Number 2 is the injection error, which is very common. It's been found out that an injection error, you have not given the right drug into the CSF. More common than what we think. Then third is inadequate intrathecal spread. And fourth one is ineffective drug action and failure in the subsequent management. We need to emphasize that one of the common causes of failed lumbar puncture is positioning. So it's very, very important that you have a firm table and a very good assistant to produce an extremely good quality of entering the space correctly. This has to be, I need to overemphasize this. Improper position, like a flat surface with a nice flexion produces the best interspace that you can ever achieve. And if you see the picture here, I'm sure that it will be very difficult. The shoulder is here and this shoulder is here and there is drooping. So we need to give attention to this, and it's so important that you keep absolutely straight so that you enter inside the space properly. And I always like the sitting position because I find it very easy, but it is inter-individual variability. Even in the history of anesthesia, if you see the first spinal was given in the sitting position. But when you choose a lateral position, make sure that you handle the patient very gently, but this is the most appropriate position. You see that you keep the shoulders straight here and the pelvic tilt doesn't happen. The third lumbar interspace is considered to be the best. The midline approach is considered to be the best, but when you use the midline approach, the needle insertion should be exactly in the middle. The needle shaft should be at the right angles to the back. These are the small things which you need to think before you put the needle inside. And the third thing is, if you have an obstruction to the needle, the movement, first try a small cephalad movement, a very gentle cephalad movement of your needle. And if you again hit the bone, then you need to go occasionally chorded angulation. This is a prescription that's been given for the beginners who start the journey of spinal anesthesia. Now, certain tips for a failed spinal. What happens when the spinal fails? And the patient is anxious, but the anesthesiologist is much more anxious than the patient. But I have a trick. When it happens to us in this unit, you tell the patient that the drug we gave, but unfortunately it has not taken. And the next statement, which produces a tremendous amount of confidence into them, is, you are much more stronger and powerful than we thought. So that's why you need more drug. Immediately there is a grin and they feel so happy and positive inside that it's not because of the anesthetist who gave the drug, it is because of him that is so strong and he needs so lot of more medicines than thought. So he was thinking that he was a weak patient, but we gave him an assurance he's pretty strong. This makes a positive energy there, and patient feels very comfortable. This trick really works, and I really do this. And next time when you're going to repeat a spinal, make sure that you infiltrate local really nicely and make an absolute identification of the midline. Majority of the times we fail because the patient is very obese and you do not know whether you're in the midline. And majority of the times it's also difficult when you have patients who come with fractures. So it's a dictum in our unit that majority of these patients, especially who have hip fractures, we give a block preoperatively, a femoral block, and then position them for a combined spinal epidural or a spinal. It becomes so comfortable to do the procedure and the patient doesn't shout. And of course, at present, no lecture in this regional anesthesia conference goes without using the word USG. So USG is another one where it helps us to identify the structures. One method which I have found it very useful in my clinical practice is if you use a combined spinal epidural, the spinal needle has got a sheath covering it which measures about 10 centimeters. When you see a patient who is very obese and you do not know where is the midline, I use this technique. In every patient, however obese they are, you see the intergluteal cleft. So what I do is I take out the sheath that is covering the spinal needle, I put it from the intergluteal cleft up. Or you can use any measurement scale which you can use it from the tip of your intergluteal cleft and see that you can detect the midline. So this is one of the improvisations and the easy method to aid us to show. Yesterday Dr. Chan was telling that you ask the patient to feel the back, but most of the obese patients cannot take the hand down back to feel their, I mean it, because many times it doesn't reach their back because they're morbidly obese that the finger doesn't reach the back. So this is a simple technique, and believe me, I use it very regularly, and you're highly successful in getting the midline with this simple procedure. This is how I do it. You make a mark and then go and then give the drug. And as I said, for hip fractures, we give a preoperative femoral block and then make them sit very comfortably. You had sessions on identifying the intrathecal space with the help of ultrasonogram, which is an additional point of identifying it in difficult situations. Now, the end point has always been a clear fluid CSF coming out, but many times, especially patients who are undergoing labor analgesia, the fluid that is coming out is the epidural infusion that you are giving when you decide to go for a spinal, which you need to be careful. And occasionally, very occasionally, it is because of the presence of congenital arachnoid cyst, which again a clear fluid comes out and then it is not CSF. Many of the studies have indicated inappropriate dosing and spillage of the drug, and error in the medication has been the other cause of failed spinal, much more than actually what we think. One of the best ways to do it is always when you go for a VIP case or a case which is slightly of a longer duration, it's a great idea to go for a combined spinal epidural anesthesia. And whenever you have a difficult spine, especially if you're able to identify the midline, then a good option is to go for a combined spinal epidural technique, because even if the spinal fails, you can top up with the epidural. And we have plenty of needles which are available in the market, but those who are using pencil point needles have to be very, very careful, because you need to introduce it appropriately. So this is called as a flap mechanism. See, this is the epidural space, this is the subarachnoid space. When you put the pencil point needle inside, sometimes the dura acts as a flap. So when you aspirate, the CSF comes out like this, and then what happens is this flap goes back. And so when you inject the drug, this flap goes and occludes this lumen, and all the drugs goes into the epidural space or the subdural space. So this is another cause of a failed spinal anesthesia. And one of the measures that has been told us, like it was presented also yesterday, if you do a 360-degree rotation of this needle, it seems the flap mechanism doesn't happen. But you need to be very, very careful while doing it. Then anatomical abnormalities can result in a failed spinal. The baricity is very important. For beginners, it's best to go for hyperbaric solutions because it is very, very predictable. And I have a good news for you. If you want to tell the surgeon that you give spinal, the next spinal also fails, there is a new entity called as local anesthesia resistance. It is supposed to be because of a mutation happening in the sodium channel. This is a new research. But it's good for us. So if third time it fails, we can say this is because of local anesthesia resistance and it doesn't affect our ego. And please do not mix the drugs when you inject the drug, because the baricity, the pKa changes. So whenever you want to inject the drug, two drugs, an adjuvant, I really urge you to do it in two separate syringes. Do not mix it. And best is to use an insulin syringe. I feel this is very important, because when you use an insulin syringe and for example, I use a lot of clonidine intrathecally. I take it in the insulin syringe, and with an insulin syringe, if you aspirate, even with the 27 needle, the CSF flows very smoothly. And the amount of pressure that you exert on the spinal needle is very less when you use a insulin syringe. But the same thing, if you use a 5cc syringe and try to aspirate it, you are bound on many occasions to displace the tip of your needle from the intrathecal space. So I strongly urge, do not mix the drug and use a clonidine syringe for it, so which I found to be very clinically very useful. So adequacy block is tested by the modified Bromage score, and I think all of you know about this. So it's very important to do this, and after 15 minutes if it doesn't work, that means, so after 15 minutes if intrathecal administration is not taken, it's a failed spinal. And what are the options? Whether to go for a repeat block or go for general anesthesia. Now there is abundant literature to show for for a repeat block, but much more senior, much more care while giving it, or the next option is to go for a general anesthesia. And this is the last slide which I wanted to show. 562 complaints were received by AstraZeneca globally over a 6-year period from many countries worldwide about the bupivacaine ampule that they didn't work well. An analysis done on multiple labs not associated with AstraZeneca, and every time in this 560 time it was proved that the product was normal. So we are not only the people, the whole globe does it. So thank you very much for your patient hearing.